Hello everyone, we are back here at the ACR, and today we have the great pleasure of having Professor Distler, who's going to talk to us about what does he think about the new ACR-ILD recommendations and how this could be implemented, also looking more specifically at patients. Hello Professor, good morning.
Good morning, Corrado. I think our colleagues at ACR have done a wonderful job. I really like the presentations. The recommendations are very useful. How they will guide us what we do in clinical practice. And they created a list of medications that is reasonable to use in Scleroderma ILD and other CTD ILDs. We had a session after the guideline session where we were discussing how to apply them. And I think what is important, the ACR guidelines provide a hierarchy of certain medications, either as a start of therapy or upon progression. But I think what is really important is when you choose those medications in the list, despite there's a hierarchy, what is very important is that you take the patient phenotype into consideration. So for example, some of those medications are getting their evidence from a very specific population. Specifically, tocilizumab has been tested in early inflammatory scleroderma ILD. So I would use it for that patient population. And second, I'm looking at the evidence level for the certain medications. And they are, despite they're in this list, despite there's a hierarchy, they are not the same. So in my opinion, for example, tocilizumab, nintedanib, MMF has a higher evidence level than rituximab, where we have smaller randomized controlled clinical trials. So I'm personally not using rituximab as a first line, but as a second line therapy. So patient phenotype, grade of evidence, and of course, patient-specific things like patient preference needs to be taken. Toxicity, of course, needs to be taken into account.
Thank you very much. Thank you very much, Professor. That was really helpful for us. And thank you all for following us.